Sawairi Tonsao. Good morning, everyone. I'm Yuki Amano from JICA project for developing a continuing professional development system for nurses and midwives in Lao PDR. It's my pleasure to be your moderator for today's session, and I'm truly delighted to be here with all of you. Thank you for joining us. So today, we have the honor of welcoming 6 distinguished speakers from Laos. They come from diverse backgrounds, government officers, and medical institutions. But they all share the same commitment, ensuring that patients in Lao PDR can receive high-quality medical services with confidence and peace of mind. Today, the key phrase for today's session is filling the gap. This may resonate with many of you. If you work in the medical field, perhaps you've thought we've received these directives from the government, but implementing them is not always straightforward. Or if you are involved in policy making, perhaps you've felt we created these policies based on the field research, yet we see challenges in their application on the ground. Even though we share the same goals, it's not uncommon to notice a gap between health policies and their implementations. Today's session aims to explore this important topic. Here's how we'll proceed. In the first part, our 6 speakers will present their perspectives and effort under the theme between health policy and implementation, effort to improve service quality in health facilities in Lao PDR. And the second part, we will open the floor a discussion with our speakers and participants, focusing on how to bridge the gap between policy and practice. And I encourage you to actively participate in the discussion. It's an opportunity to share ideas, insights, and solutions. Okay, let's begin with presentations. Please join in welcoming our first speakers. The first speaker is Dr. Shinsuke Miyano, JICA Health Policy Advisor to Ministry of Health. He will be presenting on overview of the health sector reform strategy 2021 to 2030 in Lao PDR. Please start.
Thank you so much. Good morning, everyone. Thanks for coming for this early morning session. And very appreciating JICA to give us this opportunity focusing on health system in Laos. So my name is Shinsuke Miyano, serving as a JICA Health Policy Advisor to the Ministry of Health Lao PDR. But before our diving into details of health policy in each area, please allow me to explain a high-level overview of policy direction and the policy strategy and the implementation plan, as well as the key challenges. So, as a Lao government, normally Lao government has a policy structure. It's anchored by Vision 2030 and together with National Socioeconomic Development Plan. So this multi-sectoral high-level strategy aims to increase the gross national income per capita by 4 times by 2030 and elevate the country to the status of upper middle country. So this is a big overview of the strategy direction. And to operationalize this strategy, we have the 5-year socioeconomic development plan serves as a concrete implementation framework. For the health sector, also align itself with this government policy structure, specifically Health Sector Reform Strategy 2021 to 2030, outlined our policy direction, while the 5-year Health Sector Development Plan focusing on details, implementation, and progress tracking. The Health Sector Reform Strategy 21 to 2030 aims to achieve the universal health coverage by 2025. graduate from the least developing country status by 2026, and achieve health-related SDG goals by 2030. So to achieve these milestones, the strategy emphasizes 5 priority areas: health services, human resources for health, health financing, monitoring evaluation, and the governance. In line with this strategy, the 5-year health sector development plan facilitates the implementation of strategy through the 8 programs, 47 sub-programs, and 126 projects, all tied to the budget and allocation framework. And progress also has been tracked using 11 core indicators, which are regularly reported to the National Assembly. So to ensure this effective policy implementation, the Lao government employs a sector-wide and a multi-sector coordination approach. So within the health sector, we have 5 technical working groups correspond to the 5 priority areas outlined in the strategy. And each technical working group monitors the progress in each area and report to the sector-wide group where the Ministry of Health and developing partners address cross-cutting operational policy issues. And furthermore, the health sector working group reports to their progress to the government roundtable, which serves as an official high-level forum to discuss and deliver the recommendation to the cross-cutting issues in the challenges. The health sector working group and the government roundtable meeting happened last week, actually. And then 4 key challenges health sector are identified. The first one is limited public finances for health due to economic crisis, as well as a donor transition as a trade-off of socioeconomic development. Second one, inadequate coverage of quality and safe health services across the health facilities. The third one is that fragile social protection for health to protect the household from the catastrophic health financing by minimizing out-of-pocket payments. And lastly, the under-resourced and insufficient skilled health professionals meeting international and regional competency standards. So JICA has been collaborating with the Ministry of Health to address these challenges through policy formulation and then facilitating the implementation of policy. However, as we already mentioned in the title, bridging the gaps between the policy and the implementation remains a complex and evolving challenge for all of us. So from now on, we are going to ask the policymakers and the implementators in Laos to explain about each area's policy and implementation. And after the session, we also want to have some interactive discussion. So we are also looking forward to hearing you and your experience in your field about using our case of Lao, thinking about health policy implementation. Thank you for your kind attention.
Thank you, Dr. Singh. He shared valuable insight on health policy direction and implementation plan and challenges to achieve the UHC. Now, let's move on our next presentation. Our second speaker is Dr. Somchan Sawa, Deputy Director General, Department of Healthcare and Rehabilitation, Ministry of Health. His presentation is titled National Policy to Improve the Quality of Healthcare Services.
Sabadi. Good morning, ladies and gentlemen. First of all, dear symposium organizer and distinguished audience, I am Dr. Somchan Thuswat, Deputy Director General, the Department of Healthcare and Rehabilitation, Ministry of Health of Lao PDR. It's my great pleasure to have the presentation here titled Policy to Improve and Quality of Healthcare Service. The presentation divides into 4 topics follow. The first, efforts to improve the quality of healthcare service in Lao PDR. The second, overview of 5 good and 1 satisfaction quality of healthcare facility. The third support from JICA Technical Cooperation Project for Quality Improvement Effort in Lao PDR. The last topic, achievement and challenge. I would like to start with efforts to improve the quality of healthcare service in Lao PDR. The Ministry of Health of Lao PDR has been focusing on ensuring that the people have access to quality essential healthcare service to achieve universal health coverage. The 10 minimum requirements applied the maternal and child health service are the first to aim maintain the quality of healthcare service to a self-assessment approach. To achieve universal health coverage by 2025, the health sector reform strategy framework 2013-2025 included healthcare service supply and hospital management as one of the 5 pillars to be addressed. Positioning is an essential issue. So in 2016, the National Assembly adopted the policy 5 good and 1 satisfaction to improve the quality of healthcare service as on level in Lao PDR. And this policy focusing on the main point of service quality consisting of the 5 good and 1 satisfaction as good, welcome, well cleanliness, well convenient, well accurate diagnosis, well and quick treatment with good result and patient satisfaction. So the second topic, the first slide show of the overview 5 good and 1 satisfaction 1G1S standard consists of domain, health facility foundation, health facility management, clinical care, quarantine center service, and client satisfaction. The 5 good are captured in clinical care and client center service standard, and 1 satisfaction component are in client satisfaction standard. Health facility foundation and health facility management are also included in the 5G1S standard, as they are considered back office or building back block for every health facility. Health facility management included financial management, included health insurance management and human resource. So effectively implement 5 good 1S policy, 5 good 1S standard for health facility were developed approved as the national quality standard and published in March 2002. These standards have been applied to all health facilities in Lao PDR. So the third topic shows the support from JICA project. JICA project, Technical Cooperation Project, have supported quality improvement efforts Lao PDR. The HISMI project from 2002-2007 supported the introduction of 10 minimum requirements for maternal and child service. This was then rolled out nationwide. The 5G1S policy was adopted in 2016, and the QHC project supported by quality improvement at provincial and district hospital in the 4 southern province from 2016-2021. The QHCF project standards in the 2002 has been implemented in all provincial and district hospital in the 4 southern province in line with the 5G1S policy and 5G1S standard, and has been expanded to include assessment and continuous quality improvement activity. So this slide shows the cycle of continuous quality improvement activity. In brief, or the consist of 4 steps: disease target standard, make action plan, monitor activity assessment and review. Each hospital implement this cycle every 3 months. So the last topic, as ASIP and SARENS, the Department of Healthcare and Rehabilitation is working to implement the 5G advanced policy on the quality of healthcare service towards collaboration with the Reliance Department with the Ministry of Health, Reliance Health Facility and Development partner included JICA. In the 4 southern province, together with the JICA QACA project, we promote training on the quality standard assessment using quality standard and quality improvement activity based on assessment result at each provincial hospital and district hospital. In addition, the organization such as Luxembourg Development and ADB and WHO are supporting other provinces. The progress of implementing the 5G Advanced policy nationwide very widely allocating sufficient budget for quality improvement is also and also the DHR discuss leveraging quality standard and establishing a hospital certification system using assessment. Finished. Thank you so much for attention.
Thank you, Dr. Samchan. Okay, next, I'm pleased to introduce Dr. Ladawan Sendala, Deputy Director General, National Health Insurance Bureau, Ministry of Health. She will talk about national health insurance to improve access to healthcare services.
Good morning, ladies and gentlemen. My name is Ladawan Sendala, Deputy Director of National Health Insurance Bureau in the Ministry of Health, Lao PDR. It's my pleasure to present you about the overview of National Health Insurance Program aimed to improve access to healthcare services. This presentation will cover the government goals, evolution of the current system of the national health insurance, the challenges we face, and the way forward. The government's goal is to achieve universal health coverage by 2025, ensuring all people can access to the health services they need to become and stay healthy without suffering financial hardship, and to reduce out-of-pocket expense to 30%. The goal of achieving universal health coverage in Laos includes 100% population cover for the poor, specifically to health insurance card for low-income family, and a national health insurance cover rate of 94.5%. The service cover all outpatient and inpatient services. Members will pay a co-payment at the point of the service in different levels of the health facility, excepting poor families and pregnant women. To provide good quality services, the Ministry of Health implement 5 good one-star detection strategy, along with the essential health service package and strengthening human resource for health. The evaluation of the health insurance system began in early 2000s, focusing on the public, private, and voluntary informal sector. Before 2015, we introduced the Health Equity Funds and implement free maternal and child under 5. At the same time, National Health Insurance Scheme also began between 2016 and 2018. We pilot a harmonization of the formal sector under National Social Security Fund of Ministry of Labor and Social Welfare. Along with the informal scheme under Ministry of Health, by 2019, we expand and harmonize the system across 17 provinces. The current social health protections cover village population and have really increased in the introduction of National Health Insurance Scheme or NHI scheme in 2016, rising from 30% in 2016 to 94.5% in 2023. You can see a difference. Informal and formal scheme is cover different percentage of the coverage. Social health protections in Laos is managed through two main entities. The National Social Security Funds, which established the State Authority for Social Security, or SHAS. For civil servants or the independent spouse and children, and Social Security, or SSO, which cover employee of private and enterprise in company along with their dependent spouse and children. This scheme managed by Ministry of Labor and Social Welfare. The finance source for this system come from compulsory premium. Ministry of Health has also created informal cover for residents in 17 provinces and the capital city who are not included in other health schemes, such as community-based health insurance, health kitty funds, and free health care for maternal and children under 5. The funding for this formal cover is sources from tax revenues or the government budget, and also they have 50% for the premium for the informal. In 2019, health benefits from National Social Security Funds were transferred to the National Health Insurance Scheme managed by National Health Insurance Bureau, Ministry of Health. In addition to the implementation process, we face several challenges. The main issue is the fragmented management of the health insurance, which lead to unclear government structures regarding social protections. There are key components: social welfare and social security, which are managed by Ministry of Labor and Social Welfare, which health benefits are transferred to NHI scheme managed by Ministry of Health or National Health Insurance Bureau. Therefore, we need to have future discussion regarding to benefit package provider payment system. Financial sustainability remains a significant issue for national health insurance system due to underfunding. The situation leads to delay payment to the health facility, as the National Health Insurance Scheme rely heavily on government budget allocation. Additionally, rising healthcare costs influenced by economic crisis and increased inflation contribute to the insufficient resource allocation. The next challenge is achieving the population coverage in private sector due to limited enforcement of self-employment enrollments in the Social Security scheme, with these populations being automatically enrolled as NHI members in provinces. Assessing healthcare services and ensuring quality, especially for vulnerable populations, is low national health insurance premium, limited cover for medication and medical supply. Additionally, there are insufficient incentive to promote quality improvements. The final challenge is the ability to manage effectively. Currently, the standardized data system for monitoring, reporting, and reimbursement under national health insurance are still in development. The existing system depends on paper and Excel file to consolidate data, submit revision, file claim, and support decision-making. Additionally, there is a limited understanding of health insurance management among both healthcare provider and member. The next step to move forward by streamlining management and designing comprehensive benefit package that integrate different schemes for both the formal and informal sector. We advocate for independence of National Health Insurance Board to serve as a single processor and operate as a semi-autonomous agency with a budget capability to ensure adequate funds for national health insurance scheme. We will hold strategic meeting with stakeholders, including the Ministry of Finance, Ministry of Planning and Investment, to promote increase the investment to health sector. Additionally, we will explore alternative financing mechanism focus on improve with the revenues collection. The next step to strengthening the medical claim review process by implementing an ICT system that enhance the quality assessment, efficiency, and transparency. Additionally, we will focus on improving the understanding of the health insurance management through advocacy for health insurance member, provider, training for health insurance team, and according awareness campaign. This is all my presentations. If you have any information, please ask. Thank you very much.
Thank you, Dr. Ladawan. Our fourth speaker is Dr. Kampason Tepanya, Director General, Department of Health Personnel, Ministry of Health. His presentation focuses on human resource for health development strategy for better service provision.
Good morning, everyone. I am Kampason Tepanya from Department of Health Personnel, Ministry of Health, Lao PDR. Today, I am very exciting, happy to come here. Not only the important conference, but beautiful and historical city of the Japan. What I am going to share with you today is HSR development strategy for better service provision. First, I will talking about introduce you to get to know Lao, and after that I will show talking about what is the challenge, original challenge in the HSR area, and also I will present the overview of a HSR strategy for the next 10 years and some achievement and remaining challenge that we have to tackle in the future. As you can see in this slide, Lao is situated in Southeast Asia, surrounded by 5 countries. We then connect with the sea. It means that we are landlocked, but we have beautiful natural and visit site. If someone want to go to Laos, you can go. Yeah, so this year is the tourist year of the Laos. Laos composed of around 7 million with low density of population. Majority is Buddhist, and we have 50 ethnic group, but different language is a barrier for our implementation of the HSR also, of the service also. The Ministry of Health of Laos classify in 4 levels. The central level, composed of the department that to formulate the policy regulation for all levels. And after that, we have also the principal central principal hospital and some technical center. And in the province level, we have provincial health office, provincial hospital, and also college of health and school of nursing. And in the district level, we have a district health office and district hospital. The mainly district health office or provincial hospital is mainly focused on the prevention, but the hospital is the curative work. And in the village level, we have a health center. How we can classify this in the district? You can assume, you can imagine that the district population of the district around 30,000, something like that. And province, the maximum is 1 million. The lowest is around 100,000. You can compare with your country. It's maybe totally different. The human resource women's strategy, the original challenge is, of course, we didn't have enough staff shortage. If compared with the WHO recommendation, we have only 1.4 per 1,000 population. And also even we produce around 2,000 per year, but we cannot absorb to the system is the challenge. And many of the health centers, we have around 1,000 health centers, not meet the minimum standard of the number of the health workers. In terms of the quality of the human resource for health, the health education institution it not meet standard, and we don't have yet QA of institution, and training system we have is weak. We can say is weak. We need to improve the governance of the HR management. Even we have the database, but timely accuracy is one concern of we have to do. And even we have the provincial health workforce planning, but the monitoring to implement is one thing that we have to try again. And also the private sector is growing up, but we don't have yet strong regulation to monitor, to control them. And also the health worker, the incentive to motivate them to work hard is one thing that we have to be work harder to how can we use them effectively. The system of the reporting in H area is not systematic. The human resource for health strategy for the next 10 years be developed based on the challenge and issue that we found when we review. As I talked earlier, we set the vision and mission. What is the strategy we want to do is we want to improve the quality of training and education, and we want to improve the recruitment of and distribution of the health worker. We want to improve the governance or management of the health worker, and by doing that we have to provide appropriate incentive, and we have to think about how we provide a safe and supportive environment for the health worker. We set 3 directions, and we each has 5 strategic objectives. The first strategic objective we want to I will pass this diagram because you can see later. After the HSR strategy we issue in 2023. So after implementation, we have some achievement and progress. For the first objective, the strengthening of the governance, we can see the complete the review and update for the role and responsibility of the provincial health office, district health office, and provincial hospital, and we separate the role among each level. The health system information we also update, and we try to combine the contracting staff and other health workers, for example, military and private sector, to combine in the system. The decree on medical civil servant is approved and implemented. Why we have this special decree? Because Before that, the health worker is treated as other ministry. So the health worker is work special and work harder than, we can say that work harder than other. But we pay the same, we treat the same. So why we have this decree? The strategic objective to meeting the demand, what we do is we can review and update. We review and update the health workforce planning again, and we revise the projection according to the staffing norm. And even we have the few posts from the government, because to recruit the new posts, we have to wait the quota for the government. Even we have the little posts from the government, but we focus on the PhD level, because PhD level is the most needed for the service. The objective 3, the licensing and registration of the health professional is in place and implement, and also the continuing professional development system is create, and especially for the nurse and midwife with support from JICA now. For the next 3 years, we work together, and also the role, the function of the healthcare professional council is revised. And for the objective 4, improve distribution of and retention, we conduct the workshop for provincial health planning. Is we can involve the district and province to work together and discuss how can we fill the gap, how can we solution the HRH issue, and also we conduct research for retention, because this last few years, we facing with the financial issues, so many health workers tend to move and tend to early retire. So we conduct the research for how to zone in the future. For the objective 5, we complete the job description in some throughout the country in some part, and we pilot the workload indicator, staffing need, because of in the past we just set the standard and calculate the need of the health worker, but some health facility is considered to be low productivity, low workload, so we now piloting how can we change our staffing norm, and also we conduct the consider the award for the health center. Why we do this? Because we want to motivate health workers to work in the rural or peripheral area. For the other issue that cross-cutting with other things, we consider when we recruit or when we consider the promotion of the health worker, we consider the ethnic group, we consider the gender, we consider, yes, also the remote area. You can see this in the, as according to our information we have since 1976, you can see the number of health workers in Laos is increased. Yeah, but come to this year, it tend to decrease because of the government cannot inject more health workers. Is one challenge also to meet the WHO 4.5 is difficult for us. And the remaining challenge we can share with you is still shortage in terms of number, quality, and ratio population. And still many health centers don't have enough minimum standard of the health worker, and moreover the high turnover rate. This time is a big challenge for us, and Also, even we have the human resource strategy, enforcement, monitoring to implement, and resource allocation to implement is one thing. Also, our health worker is skill in management on in HRS is one issue also. We have to work hard. I think I finished my presentation. Thank you.
Thank you, Dr. Kampasan. Okay, now let's hear from Dr. Nopaban Banusip. Sorry, Dr. Nopaban Banusip, Director, Health Professional, Council Bureau, Ministry of Health. Her topic is license registration, continuous professional development system to enhance the quality of professional health workforce.
Good morning, ladies and gentlemen. Today I would like to present you about the licensing on Lao PDR. Dr. Kampasong, Director of Health Professional, explained the general situation of human resource for health in Lao PDR. It is progress with national strategy, remaining challenge and upcoming plan. I will focus on the efforts of Ministry of Health in Lao to improve the quality of health professionals, such as medical doctor, nurse, midwife, and dentist. Background: for a long time, people in Lao PDR can claim themselves as medical doctor, nurse, midwife, and dentist. Once they graduate from medical, nursing, or dental school, there was no national examination, no license, legislation, and continuous professional development system. It means there was no standardized system to assure quality of health professional knowledge and capacity. ASEAN MIA aims to facilitate mobility of professionals, including health professionals in ASEAN. MIA also works toward the adoption of best practice on standard and qualification of professionals. Citing MIA have broad regional and international connectivity to Lao PDR and positively impact on developing the license legislation continuous professional system for health professionals in Lao PDR. We are developing the system based on this 2015 strategy. I will explain more about this strategy from next slide. This strategy on health professional licensing and legislation system was developed in 2015, supported by JICA. The license legislation CPD system in my country have been developed based on this yellow book. There are 6 strategies in this yellow book, as it is listed here. We conducted midterm review in 2020 and interim review in 2024 to monitor and progress of the implementation of these 6 strategies. Strategy 1, Health Professional Council in Lao PDR is under Ministry of Health, but independent in each technical and professional authority. HPC loan is to direct, supervise, and inspect the quality of health professionals. HPC also protect the right and benefit of both patient and health professionals. By 2024, 6 boards have been established under HPC. However, challenges remain, such as capacity of each board is still weak. For example, some board members cannot contribute to the HPC work due to their own clinical and education duty. This is the building of HPC. My office, HPC Bureau, is here. The first floor of this HPC building, you are all very welcome to HPC in Lao PDR. And this tall building is MOH. Second strategy was to develop the legal and regulatory framework for the licensing and registration system for health professionals. National Professional License is competency certificate issued by the HPC. Obtaining license for each health professional is crucial to assure the quality of healthcare service, which focus on the patient-centered care and leading to patient safety at all levels and on type of healthcare facility. As you can see, this list, we developed many decision, instruction, and policy documents for the licensing and registration. For newly graduates, for those already working in health facility for many years, for foreign health professionals, etc. However, we still miss some important legal and regulatory framework. Strategy 3 is to implement the national licensure examination, and strategy 4 is to issue license and registration. I explain the progress and challenge of these two strategies together because they are strongly interrelated. We start national licensure examination since 2020, step by step. As of 2024, all newly graduate doctor, nurse, and midwife, dentist, and pharmacy need to pass national examination and receive license to provide healthcare. For the professional health worker already working before 2020, they don't have to pass national exam. They can fill the form, send it to the relevant board in HPC. Then the board check the qualification and issue license if appropriate. We receive technical support from JICA, especially for nurse and midwifery board, to implement this strategy 3 and 4. As of 2024, total 8,882 health professionals have been received license and registered under HPC. Of course, challenge remain. First, national exam for medical doctors use many medical words in French and English. However, students graduate from abroad, such as China and Vietnam, don't know those terminology. Therefore, they cannot pass the examination. For example, in 2023, among 84 graduates from medical school abroad, only 27 passed exam. Strategy 5, CPD refers to enhancing professional competency of health professionals to keep abreast of advancement of science for the benefit and safety of patients. It is long-line learning, which is necessary for health professionals to progress, build confidence, maintain practice standard, and satisfied with their job, so patients can receive safe and good quality service. In many countries, health professionals need to join sentence CPD activity to renew their professional license. Since the issue of the decision in January 2024, JICA strongly supported MOH and HPC to develop CPD instruction and other relevant activity. The instruction is nearly finalized. System will start from 2025. The last strategy is to develop an information management system for licensing and registration of health professionals. Since start issuing the health professional license, we established a database for licensing and registration with its Excel file. When CPD system and license renewal start from 2025, the workload for HPC and my bureau will dramatically increase. A modern specialized database system is needed. There is a plan to develop modern web-based database with financial support from the World Bank, and JICA will keep providing technical support. To strengthen public communication, HPC developed a website with support from JICA and actively used Facebook page to promote the licensing and registration system. Okay, I finished my presentation, and thank you very much for your attention.
Thank you, Dr. Nopavan. Finally, we have Dr. Susada Nalongsak, representative of Medical Administration Office at Champasak Provincial Hospital. She will present on reality in a health facility for policy implementation and its effort.
Distinguished guests, colleagues, ladies and gentlemen from this room and also online participants, good morning. I am Dr. Susada from Champasak Provincial Hospital. I'm very happy to be here today to present you about reality in a health facility for policy implementations and its effort. In my contents, I will cover about three main parts. The first one is about how national policy have been implemented. And the second one is about challenge, and after that is effort at the health facility levels. How national policy have been implemented. As you see from the previous presentation that our 5G1S was adopted in 2016, and our Champasak Hospital is located in the southern part of Laos. It's a quite biggest hospital in the south. And also, we have a modern equipment than other province hospital in the south. There are many specialists in our hospital. Our hospital is the main referral hospital in the south as well. And also, we share border with Thailand. And also, we have referral system, disease system with Thailand. Southern part of Laos, a quality of healthcare and finance, or you can say QHCF model. We use this standard as the quality improvement, especially in my hospital. This slide shows you about the number of government staff and the base in Champasak Provincial Hospital. And then you will see from 2020 to 2024, you will see that the total number of medical staff decreased from 2020, 430 to 423. But the actual bed from 2020 increased from 428 to 452. And the second paragraph is talk about the volunteer and contract staff. You will see in this graph that in 2021, the volunteer and contract staff is quite high, but in 2024, it's lower. So, in our hospital, we have a JICA QHC project. This project used 5 years. And the model of this used a grade scheme as a level of evaluation. Each progress is step from grade 1 to grade 5, and we start from toilet, OPD, EMOC, and normal delivery. And after each evaluation, we will include more the ward and office to be involved in our project. And by the end of 2021, on the ward in hospital and office used a QHC model as a standard. And another for the JICA QHCF, this is a 3-year project. This model we use 2 evaluation system, percentage score and pass and non-pass score. And we divide in 2 main parts, is hospital management and clinical management. It means cover on every area in our hospital. And after each evaluation, we do for CQI. The QHCF model follow the national policy of 5G 1S. And we have 4 levels of organizations like Board of Directors, Technical Committee 1 and Technical Committee 2, and Implementer. This slide shows you about quality improvement for healthcare facility and in Champasak province. As I said that we start from 2016 and until now, we focus on CQI for sustainability. For our challenge for QI and CQI, still now we didn't have full-time staff, and also we didn't have specific office for this. And quality committee has many responsible, so it's quite hard for them to focus on CQI. Sometimes communication with the committee is quite difficult because they have so many responsible that I said. And the evaluation standards still now developing. The medical staff still focus practice more than QI. QI course is not set up in the medical university yet. And now we didn't do about formal external evaluation is not completion yet. Another challenge, the patient safety strategies have been not clear defined in each area. And also we have inadequate understanding about strategy of the patient safety. The patient safety committee is still now not strong enough. So we also inadequate knowledge about patient safety and inadequate about the data collection and report for medical error and near miss, and particularly for our staff. We reluctant to report of medical error because many people still scaring about something if you say and then it will have punishment to you. And another challenge from finance, the report and accounting is not regularly updated. And the property management is not updated regularly. And another things, contract staff outnumber of government staff. That is our challenge. And for the HI, the report from hospital to HI center, as well as the embarrassment from HI to hospital, both delay. And another thing is we have difficult of data collection from each board. And the model of HI is still undeveloped. Also, HI staff lack educate knowledge of HI scheme. And for human resource management, the data collection of staff training is not properly recorded. Another thing is work staff management is complete due to shortage of staff. For our effort, for the QI and CQI and patient safety, QI become well known among the hospital staff, and later they conduct the competition for every ward. And also the committee for QI and patient safety was established. We have adjourned to train about QI, patient safety, and hospital management by working closely with MOS, JICA experts, and but sometimes from our hospital themselves. And also in district hospital, we also have a chance to do training about QI. The QI self-evaluation was conducted at the hospital twice a year, as much as the cross-section also 2 times a year. After every evaluation, we will conduct about CQI. And on the basic of problem, we can solve, but it's not related to the budget. If related to the budget, we will make another plan. Next. And also, another things, we have a chance to exchange QI experience with Thailand, and also we have a chance to train in Japan as well. This slide shows you about assessment results using 5G and 1S from 2022 to 2024. You can see that the trend increased dramatically from 69 to 93%. So it means working closely with JICA QHCS, we have very good progress. So another effort, QHCS project follow up with the key provincial level staff in 4,000 provinces for QI and patient safety. The implementation was improved after getting feedback from on province. Patient safety activity comment, for example, training, attractive poster, etc. The patient safety guide has expanded and improved a lot. And for human resource, there are so many activities that we can improve, like a TOR, dairy, staff attendance, employee annual leave, staff general and management training, certify and record. For health insurance, we have a checklist for HSI was introduced to monitor the system to ensure its smoothly operation. In each QI hospital evaluation also address health insurance matter. HSI staff will give more train, especially data report. In this permitted, staff have exchanged experience in HSI with Thailand, especially discussion of the ECAM system. So for that reason, we want the sustainable JICA project for continued quality improvement to address the challenge in quality of health care in highly recommended. Thank you very much.
Thank you, Dr. Susada. Now, so we will move on to the discussion. Next slide, please. From the presentation, we have learned both the government and hospitals are taking significant steps to improve the quality of healthcare. However, it's evident that the gap remains between policy and practice. I hope this discussion provides us with an opportunity to explore a way to bridge the gap. Yes, to everyone here and joining us online. So, yes, if anyone here has experience addressing these challenges in your own countries or organization, we would greatly appreciate it if you could share your insight or solution with us.
I want to thank all the presenters. It has been very interesting because in all our countries, it's like we are having the same problems, especially when it comes to human resource. And where the medical field or the nursing and medical field is being placed by our individual governments. We are all civil servants, and in the civil service code, there are things that deals with everybody, your action, like he said, maldistribution of staff. In that civil service code, when you look at it, it has rules and regulations and laws telling you that you should go on rural posting and so forth. But because sometimes we don't relate with these policies that are already, we are not even aware of the civil service code. When you look at all the healthcare workers, we don't look at it because we are abusive practicing. So we have to go home again and ask for the civil service code. It gives us directions. Now, presently, we are trying to review it because it's an old code from colonial days in the 50s. And we are still dealing with the same code. Now we are dealing with new generations. So we have to look at it and then ask government to review it for our sake, because we have to practice in the new settings. For the board, council, the Nursing and Midwifery Council. Council, yes. I'm also a nurse and a member of our own council. We are having a lot of problems, especially with the training institutions of our nurses and midwives. What we have decided, first of all, our act has been enacted in Parliament, so it's now a law. It's a whole law. And we are mandated to accredit institutions that want to train nurses and midwives. And if we don't give you an accreditation and you train, we will not accept you. We will not give you a license. We will not give you our card to practice in the country. So if we go to that extent and ask government to give us, enact laws for us to govern us as board members or council members, then we can stand a ground to ensure that the trainings, not everybody will be training nurses and midwives all over the place. Because in the end, like the human resource said, we still have people who are volunteering because they are producing more than government can really absorb. And we don't have that ability for private. In fact, what the private people are now asking, government, it will be government's own contribution to give them trained staff who are already on government payroll. So if you have more than what government can absorb, then we are going to run into greater problems that we are already. Thank you.
Thank you so much your opinion and your explanation. Sorry, before speaking,
Yes,
please introduce a little bit.
Yes, I am Paulina Yuste, I come from Peru, and I work for Global in the LHSS project. I have to congratulate the team because you have embraced a huge work. But I think that you have a very good advantage, that you have continuity. You have continuity in the effort and in the equipment that is impulsing. How do you say it? That this work in this. No, it's a huge work. It is a lot of things to do. You are founding you are implementing the funds, no, and there's always a gap between what we decide to do as a policy maker, no, and what we happen in the ground, no, and many times policies does not take into account the differences in the country, because not all the countries is homogeneous. You have different people, you have different languages, you have a different geography probably. I don't know Lao, but I imagine this like this as my country that has a lot of differences, and you have to take that into account when you implement, no? That is a big effort. We in Peru have the same problems implementing policies at the regional levels and the local levels, no? And one thing that is always important is to monitor. You decide we do this, and then we make a standard procedure, and that's it. We are happy at the national level because it's done, but it's not done. No, to be done at the local level, at the facility level, you have to do a lot of work, and you have to monitor, and you have to adapt your policies. No, that's what I wanted to comment. Thanks.
Thank you for your experience from Peru. Do you have any comment or not from Lao?
First of all, thank you for all of your comment. I do agree with that. We produce, of course, government cannot absorb on. What we produce is according to our projection. What we want is around 1,500 per year. If we want to fill it within 10 years for the shortage of the health worker. But of course, we understand also the government cannot support, cannot provide. So why we can see that in the her slide, the contracting staff and volunteer is, of course, we produce, they don't have where to go. They have to work as the volunteer in the hospital, and we see this her PowerPoint. We have to think also because even the contracting staff number is reduced. It means that how population will get the service, the better service in the future. How the new one, the young generation to substitute the one who retire is one thing that. Thank you. Yes, and also I think for establish the policy, we consult with from the many sectors, but we should more strengthening more collaboration among many stakeholders, not only among the Ministry of Health, but other sectors also. It seems to me that other sectors not so understand Ministry of Health, especially the finance. They think, yeah, they have priority in other sectors also. For example, the road, maybe the economic, something like that. Yes, what I want to share.
They have their own language.
Thank you, Dr. Kampason. Anybody? Would you please introduce?
Thank you for your great presentation, very insightful. I'm Beth from Indonesia. So 2 questions. One about the human resources issues. So we're facing the similar issues. We produce a lot of hard workforces, but the government could not absorb, maldistribution, and then also high turnover. My question is whether Lao PDR considering about the task shifting to address these issues. Because right in Indonesia, right now, most of us introduce and encourage about the task shifting. However, we make challenges with the professional associations. And also, on the other side, our pre-service curriculum reduce the competency. So for example, if I reflect to my medical schools, I have many competency, but right now the new graduates do not have that like mine. So that's the first one about the task shifting policies. The second one is a very insightful idea about the QI from the southern provinces. So I would like to ask whether in Lao PDR, you already set up the national quality policy and strategy. And then what about the strategy to scale up this a good initiative? So again, a reflection in Indonesia, we started about the QI back in 2013. We have total 3,000 hospitals across Indonesia. And until now, we only could implement QI approach to 200 hospitals. And now we started to set up the quality indicators for maternal, for primary and healthcare. We start piloting by this year. So you can, in my country, yeah, it's very huge country. It takes years to this. So we would like also to have insight from Lao PDR and as well as other countries. Thank you.
May I share experience about the sharp task shifting? We discussed also for the task shifting in Lao PDR. I explained a little bit how we solution with the shortage of the health worker. Of course, we understand that the government cannot keep posts for us according we request. And what the government give us, we prioritize in the primary healthcare level. And even though in the primary healthcare level not enough, for example, I give you example in the health center. In some health center, it's a maldistribution also. Maybe the minimum standard, we should have one medical doctor, one nurse, one midwife, something like that. But unfortunately, we have 3 nurses. So in this case, we have to train them to be the SBA, to be the maybe common disease, something like that for the nurse, to be the at local level we don't have anyone. So people want to also maybe it's a sharp task shifting also. Give you some,
Thank you. Okay, so we have, sorry.
Okay, thank you very much for your questions. And yes, for QI, you are a big country than us for sure. And for us, we work about QI. As you can see that we work 2 periods. The first time from QHC and the second time for QHCF. From each period, we improve a little bit by a little bit. And as I said to you before, in my hospital, nobody know about quality improvement. But after work with JICA project, we know about what is quality improvement. And after that, we have competition about each ward in our hospital. But for the sustainable, it's also very important issue for us as well. But what we do when the QHC project finish, we use their strategy or learn from them and try to continue the project by ourselves. And after that, when the QHCF come, we also learn a lot from them. And I can say that from the beginning, if we compare from the beginning until now, we have improved a lot. We know what is quality of healthcare, we know patient safety, we know about QCI. Before, we don't know. So that is a good way for us to learn from JICA. And also, I think we need more to learn from JICA, because otherwise, if the project go back, we need to sustainable our routine, especially CQI. So because CQI that we focus now with QHCF project is the one thing, the main thing that to sustainable the quality of healthcare. Yes.
Thank you so much. So we have no time. So next question is last question. Yes, please. So please come to here.
I'm Karina from Indonesia also. So yeah, it's a great presentation and quite excited to see the progress of Lao PDR from the beginning, and then at 2022, especially I want to highlight about the national health insurance, and you are mentioning about that for human resources for health, the incentive are inconsistent for health staff. In our country, for hospital and health center, we introduce what we call autonomy financial management, where the health facility can manage their own revenue, so they can actually create their remuneration system that set the standard salary. So from civil servant, apart from the salary, they can top up based on the revenue of the hospital or health center. So it somehow, in some hospitals, it create more incentive and to have more staff retention within the health center and hospital. So it's not based on the budget from central level or from the government level. So just want to maybe what is the plan for the Lao PDR to improve the incentive for the health staff, so you improve the retention of the staff, whether it will be standardized into the national health system standard about the what you call to improve the income for the health staff. I think that's it. Thank you.
Thank you very much for the sharing some opinion and question for Laos. According to the national health insurance system, we rely on the government budget. I can say the political commitment for Laos is very important to allocate the budget for health insurance, especially for the health insurance premium. And according to the premium from the employer and also government, we still limited for financial resources. In terms of improve the quality of the services, we need more funding for health insurance fund to like how to be the purchasing size, like to purchase the quality of the services for the member is really important for us. And we try to learn how to improve the strategy purchasing for health insurance in terms of develop or improve the provider payment for health provider, because in Laos we use capitation and case-based payment for provider payment mechanism to health insurance system. And we need more allocate. Now it, as I mentioned, the challenges in terms of the fund allocated from government and co-payment for the informal sector. We need more enrollment for private sector to register according to reduce the government budget. And now we specific for only treatment only. We not cover for promotion or prevention yet after we started a health insurance system. Yeah, I would like to share some the opinion for the implementation for health insurance. Maybe Dr. Kamason can share more.
I would like to add more about the incentive. Since we endorse the medical civil servant decree, in that the government approved some the increase the level of salary of the health worker. That's one thing that we do in the decree in the high level. And also in the decree we say that not only the increase the salary, the health workers should have some additional payment, for example, for the contact with the patient, contact with other dangerous things. And now we have to develop the the criteria and calculate in the process of, if you ask about how the future plan, we have to develop the criteria who we should pay how much, something like that, and after that the Ministry of Finance have to understand this, also have to approve. The program is according to the hospital autonomy. They allow the hospital to generate income and pay for the health worker, but they have some struggle in the recreation of the finance also. We have to deal with the Ministry of Finance again. In the past, we used to have the incentive, financial incentive for people in the remote area, but it's not work well. I can say that not work well because of money.
Thank you. So, yes, thank you for your active participation in this last session. So, next question and last question. Sorry, I forgot seeing your hand. Yes, please.
Thank you. I really enjoyed the presentations. My name is Mike English from University of Oxford, but I spent most of my life in East Africa. I think everything you said about Lao PDR, you could say about many countries in, I think, around the world, even actually probably UK. And my comment really is, I think we're stuck in very old models of human resources for health development. So if I just take your quick example of at a health center, you need one nurse, one doctor. Why? I mean, maybe that's correct, but maybe it's just because we've thought that for 40 years and we just carry on trying to do the same. And I think we need to be much more innovative and I think the problem with the word task shifting is it's inaccurate often. And I think really what we're talking about is what skill mix do we need for the level of service provision. And I think that's a much, much bigger and global conversation. And I think a great deal could be learned from what different countries are doing and what is successful and what is unsuccessful. But the big problem is the lack of, well, in my opinion, is that the education sector is not aligned with the demand side, and the professions have their own interests at heart and are not interested in the health of the population. So I think they're big, big questions, and very interesting that you're tackling them, and I think part of a much bigger conversation. Thank you.
Let me be representative for the Lao team. Thank you for all of your question and comment and suggestion. Of course, you also, we have to motivate ourselves to work for our population. Yes, thank you.